removal to save their lives from cancer. Maybe they don't want an implant, or they can't do reconstruction right away, and then they have concerns down the road if they will be able to do reconstruction. Those are a lot of the questions that we are going to be answering for you today, and it's one of the reasons why it's so great to have a surgeon of this caliber here in mid-Michigan now, because it just gives patients so many more options. In fact, he can use your skin and fat to reconstruct your breast. So a lot of times that's very helpful for patients. And we'll go through all of that and talk about how that might be able to help you. We are seeing amazing results from this as well. So that is great. Now, Dr. Saab.
Thank you for inviting me today to talk about breast cancer reconstruction. Um, as you guys know, this month is Breast Cancer Awareness Month, and I appreciate the opportunity to talk more about the options for women with breast cancer and what can they do to reconstruct their breast. So I tried to keep it kind of simple today, and I want to just highlight what is breast cancer reconstruction exactly, who might be a candidate for such a surgery, and what are the options available. So women who have surgery for breast cancer might want to undergo breast cancer reconstruction, which is basically a way to replace and reshape the breast for them. So they might have had all the breast removed and they might want a new breast formed, or they might have had part of their breast removed and they're not happy with the looks of their breast at that point and might want to have some reconstruction for that as well. So again, the two main candidates are either you had the whole breast removed, which we call mastectomy, or some of those patients who had breast conserving surgery where only part of the breast is removed. But either because of the size of the breast they started with, they ended up with significant asymmetry in their breast. And those patients might have been a candidate for what's called an oncoplastic breast reduction if they, again, were a candidate for what we call breast conserving surgery. And I'll touch more about that down the line. So, what are your options when it comes to breast reconstruction? In kind of a bird's eye view, we have two main options. Either you use breast implants, and those could be silicone based or a silicone outer kind of covering with saline filled implants, or could be using your own tissue, which we call autologous reconstruction. And there's again multiple options under that category as well. So to go a bit more in details, when we think of implant-based reconstruction, there are two main ways to do that. Some patients might be a candidate to basically get an implant directly at the end of the basically mastectomy surgery. So the breast is removed and they get an implant at the end of it. This is called the single stage or direct to implant reconstruction. And some patients, maybe because of how pendulous their breast was or how short of skin they are, or they might want to be larger size at the end of the surgery from what they started with, a bigger cup size. Those patients might require a two-stage procedure where we do it, what we call a tissue expander, and this is kind of a picture of one form of tissue expanders, which basically over a period of few months, those patients come to clinic and we inflate this tissue expander, we fill it up with saline to stretch the skin envelope to give them more skin to work with for the second stage, upon which we will put the actual final implant in. The other option is the autologous reconstruction, and by no means this is kind of comprehensive, but to highlight the main venues in that option is you have three main options. We either use the muscle from your back, which we call latissimus dorsi flat, and those among us who go to gym, it's basically your lat muscles. and we will take the muscle with the fat and the skin on the back, and basically, which is anchored to your shoulder, rotate it to the front to give the woman a new breast. Usually, the volume of that breast is going to be smaller. So, a lot of times, those patients might require an implant underneath this latissimus dorsi flap. That's one option. Option two is what we call a tram flap, where basically we use the skin and fat from the lower part of your stomach, similar to what we call a tummy tuck, and use this excess skin and fat to reshape the breast. But in a tram flap, we're either sacrificing the whole muscle of your abdomen, of your basically stomach, your ab muscles, or part of them to be able to provide blood supply for this skin and fat to come up to the breast and basically stay alive. Option three, which what we call a free flap reconstruction. So free flap reconstruction is basically making use of the spare parts you have in your body. So anywhere we have excess skin and fat, that we can dissect those small vessels without sacrificing the muscle. We can take this excess skin and fat, bring it up to your breast, reconnect those vessels to form a new breast for you. Again, most commonly used nationwide would be what we call DIEP flap or deep flap, which is again lower stomach skin and fat. But again, some patients might not have a lot of skin and fat in their lower stomach. We might use the excess skin and fat in basically their inner thigh or their buttock area as well. So these are just some schematic or some pictures to kind of further explain what I was trying to say. So this is a latissimus dorsi flap, where basically we use the muscle from the back, we rotate it to the front with the skin and fat to give a patient a new breast. The tram flap is we take the skin and fat, this dotted line right down at the bottom of the screen, basically is the skin and fat we usually take. We take it with the ab muscles and we rotate them up, and you can see between the picture on the right and the left, you are one set of muscle short on the one on the right, just because it's the provide the blood supply for the tram flap. The DIEP flap is or the free flap is basically when we take the skin and fat, we do not sacrifice the muscle, we dissect those small vessels through the muscle, and we take them up to the chest and connect them. By that way, we also preserve the basically core muscles of the stomach or the abdomen. Lastly, a quick word about what we call oncoplastic breast reconstruction. So, not all patients require removal of all their breasts to get rid of the cancer. So, some patients we might just need to remove what we call a lumpectomy, or a small part of the breast that has the cancer. Oncoplastic breast reduction is an option for some of those patients that have larger size breasts. We can design what we remove from the breast that has the cancer in such a way that what we leave behind, we can still shape and make a breast out of it. And this is what we call oncoplastic breast reduction. In that case, the patients will end up with a slightly smaller breast size. We would have removed the cancer containing breast tissue, and what we left behind, we can still make to look similar to a breast. And that's kind of all I have for you about options for breast cancer reconstruction. So I'm happy to answer any questions.
And we do have some questions coming in. If you would like to ask Dr. Saab anything, text me at 248-9. From Joanne, how long is the reconstruction process?
That's a really good question, Joanne. So I tell my patients we are married in this reconstruction process for a good year. From the time of having surgery to get the final basically results, a lot of times patients might require a few touch-ups. We might do some fat grafting, especially for the upper part of the breast. Or they might require what we call nipple reconstruction if their nipple got removed from the cancer surgery, and usually those are staged procedures. So I usually try to set up an expectation of a year of reconstruction from time of surgery for cancer to final results.
Kind of piggybacking on that, we know that implants only last so long. When you're doing a reconstruction, is there a lifespan on that?
Implants have a shelf life, just like a knee replacement, hip replacement, so on and so forth. So even though the technology is getting better, those implants are lasting longer. There's always a chance of either breakage in those implants that might require them to be changed after a period of time. When we use your own tissue, it's a bigger investment up front because it's a bigger surgery, but kind of pays dividends down the line in a sense that once you have this tissue and it survives and it's healthy, there's no life expectancy on your own skin and fat, so it's always there.
Kathy wants to know if reconstruction changes the risk of her cancer returning.
Good question. So, to the best of what we know, reconstruction itself does not increase or change the risk of you getting cancer again. However, I do have to highlight implant-based reconstruction. Now we know more and more about it, that it is associated with a very rare kind of lymphoma that I kind of discuss a bit more in details with my patients who decide to go down the route of using implants. It's quite rare. We know it's associated with one kind of implants that have a bit of texturing on it. But again, it wouldn't increase your risk of necessarily to get breast cancer again, but potentially have a small risk of getting a new kind of cancer, which we call lymphoma. Quite rare again, but it's something that might happen.
And does it make cancer detection harder?
Nowadays, radiologists are really, really good in reading mammograms, reading MRIs. So I would say we know from data that usually with the new advent of again, good technology, good radiologists, there shouldn't be any difference in detecting those cancers.
Donna's asking, if I opt for a tissue flap, will there be pain, scars, or other changes in the parts of the body where the tissue is taken from?
Absolutely. So the pain process, or when we do the using, let's say, using your own tissue from the lower part of the stomach, you will have basically a cut from one side of your hip to the other. So you'll have a scar of like a tummy tuck like scar. We try to keep it as low as possible. So that's one additional scar you will have that you would not have had if you'd had implant-based reconstruction. Um, and the pain process usually for using your own tissue or the recovery phase is a bit more, I would say, protracted when we compare it to implants. Implants are usually faster recovery because again you're having less cuts on your body. Um, so yeah.
Um, when you're if you're taking some of the skin or fat from like the stomach area, then do you do like a full tummy tuck on that or?
Actually, yeah. So the kind of you in a way with getting rid of the excess skin and fat on your lower stomach, and you do get kind of the tummy tuck kind of positive outcome of that as well on top of the breast reconstruction. And I frequently also kind of if patients have what we call splaying of their ab muscles or what we call diastasis from previous pregnancies, so on and so forth. I also tighten those muscles during the same procedure to kind of give the effect of a tummy tuck.
Do you do something on the other breast? Like if you reconstructed one breast and it was higher or smaller or, different than the breast that they have?
Absolutely. So frequently, cancer might be limited to one side of the breast. So those patients might get reconstruction for that side, and we frequently need to do what we call a contralateral surgery for symmetry. So it might be we need to make the other breast smaller. So we do a breast reduction on the other side to make it to match to some extent the reconstructed side, or they might require what we call a breast lift. So we will do that to the contralateral side. So there's a few options that we might need to do to the other breast side to kind of make it match to the reconstructed side.
Lisa says, well, I have feeling in my reconstructed breast.
So mastectomy, when they remove the whole breast tissue, the nerves that supply the sensation to the nipple are removed. So patients are usually insensate in their nipple at the end of surgery. Around a year out of surgery, some patients might feel some form of a sensation, but it's never back to what it used to be before. So, yeah.
And then this is the final question that I have. It's kind of related to one of the ones you answered before, but Jen wants to know if reconstruction interferes with chemo or radiation if it's needed in the future.
So Jen, if you get a complication, and that's for any kind of surgery, so you get wound breakdowns, you get an infection from an implant, or anything that might delay your healing phase. Unfortunately, we asked the radiologist to kind of hold back on or the oncologist to hold back on some of the chemo or the radiation therapy, because that will hinder your healing even further. So we might need to wait till either infection under control or implants removed or wounds have healed before we proceed with the treatment. And again, sometimes some patients are a higher risk for some of those complications, so we might even not offer them reconstruction because, let's say, they have advanced disease or aggressive disease, and we really want them to get started with their chemo and radiation. So those patients might go through this phase and they might still be a candidate for reconstruction after that is over and done.
Okay, thank you so much, Dr. Saab. And thank you everyone for joining us. You can request more information